Yes, it's gonna, hold on, give it a sec. Recording pending.
Aha, okay, here we go.
Cool.
Okay, so yeah, welcome to the first session of the year. My name's Preena, Izzy's also here, Tina's also here. There's a few others of us, you'll meet us as we teach. So the plan for this year is we're just going to do sessions for you guys every Monday at 6. It will mainly be myself, Izzy, Tina, Divya, Mark and Jane that are doing the teaching. Sadly, Anush has to be a proper doctor now, so he can't teach us anymore. And the idea is we'll do exactly what we did for you guys last year in 4th year, but with 5th year. So start out mainly making it like based on separate modules, and then slowly towards the end of like next term, later in next term, start crossing modules and making it quite case-based. It will still be just as interactive. And there's no set schedule that we're going to try and cover every module by the end of the year. Like if there is a topic you're struggling with it, we're here to teach it for you. So basically just put it in the feedback. That's where we get most of our ideas to teach things for you guys from. And most of the updates will come on Facebook. So if you're not in the Facebook group already, we'll put a link at the end actually. I think Izzy might be able to do that. And I've written plus or minus on Instagram because we've been told that that's the way people's social medias are going, but I've just not had the time to make an Instagram for you guys yet. There will be one. It won't be very much different to the Facebook. It might just be signposting to the Facebook group. But yeah, keep an eye out for updates on there. Okay, so today what's going to happen is I'm going to do a run through of some like initial bits of obs and gynae, and then Tina's going to take over and do some psych. As usual, we're going to try and keep it as interactive as possible. And if you have any questions, just throw them into the chat as and when. So yeah, I'm going to crack on with some obs and gynae. So with obs and gynae, it is new, but like the process for the way they treat the patient is the exact same. So you do your like history, you do your exams, you investigate them. That's the exact same. And what I'm going to do is I'm going to take you like roughly through some of the like key differences from 4th year versus like an obs and gynae patient in that process. So in terms of the history, like you've got your presenting complaint, past medical history, all of that jazz. What other bits do you think we need to ask in an obs and gynae history? What like main categories can you think of? Last menstrual period, yeah. Children and pregnancies, yep. So those two I'm going to put as like, yep. So currently you've said a menstrual history of some kind and like a previous obs history of some kind. Yep. So Patrick, that comes under a menstrual history as well. Yep. Can you think of any other like broad categories? Preeclampsia, yeah. So previous obs history. Yes, a sexual history if they're sexually active. Yep. Exactly. Yep. So we've got past obs history, sexual history, menstrual history. If there's a past obs history, there's a past. Niraj, we can see your messages in the chat. Yeah. It might be one of those like refresh. Yeah, sorry. I don't think I can help you there. If there's a past obs history, there's a past gynae history. Yep, perfect. Okay. So you guys have got the main ones. The other ones to think about, which I used to always forget, is contraception and cervical screening. And there's a whole bunch of new presenting complaints. But basically, that's an obs and gynae history. It's like a normal history with those additional bits. And it can feel like it's huge. But as you practice, I promise, it is just about practicing. It will get easier and you know like what order works for you when it comes to asking things. In terms of the examination, what kind of things do you want to examine a pregnant person with? Like, what kind of examinations do you want to do? The usual ones, yeah. Plus speculums, yeah. Abdo exams, specifically a pregnant abdomen one, yep. A vaginal exam. Anything else? Yeah, okay, so you've got most of them. Pregnant abdomen, speculum and VE plus swabs and catheters. So if you're on obs and gynae right now, I would basically recommend getting those done over and over again. In terms of the VE, don't go too crazy. Like, I don't think anyone expected or ever asked me to like tell you how dilated someone was. You're never going to need to know that. But you should be able to like safely talk to a patient about what you're going to do to them if you had to do a VE. With VEs and catheters, the first ones, if you're like not quite confident, the good ones to do are when they're in theatre, so when they're in gynae theatre or they're about to have a C-section, because they won't feel it. So that's my tip for the examinations. I'm not going to teach you how to do those because you've got a great clinical skills team. Okay, investigations. What investigations can you think of that are new from 4th year that they do in pregnant people? Ultrasound, yay. And before you get to the imaging, you've got the like basic bedside ones, bloods, anything else? Urine dip, yeah. A pregnancy test, blood pressure, yep. Exactly. So I categorized it into bedside bloods and imaging, and the key bedside ones are a Doppler, a CTG, yep, exactly, and a pregnancy test. The main bloods are something called PET bloods, which stands for like preeclampsia toxinemia bloods, and ultrasound. All of those will go over and we'll touch upon when we do the actual like relevant conditions. But same with the CTG, like don't go too crazy. You don't need to know much about it as much as an ECG. It's not the ECG of 5th year. Just know like the really worrying stuff. And if you're ever stuck on a pregnant person, just don't ever x-ray anything. It's always ultrasound of some kind. Okay, so new presenting complaints. Tell me what new things a pregnant person might say to you that you wouldn't get in 4th year. Yep, vaginal bleeding, yep. If they're pregnant, change in movement, yep. So reduced fetal movements, pelvic pain, yep. Yep, pelvic pain. What's a big one that also overlaps with sexual health? Discharge, yep, exactly. Okay, so these are some of the ones that I got, which are like discharge, pain, yep, morning sickness, nausea and vomiting. And some of the gynae ones I've written here are like menstrual irregularities, menopausal symptoms like hot flushes, prolapse and incontinence. And the OBS ones, which I think you guys got quite well as well, which is nausea and vomiting, rupture of membranes, bleeding, reduced fetal movements, a fever. I've just put a star next to discharge and pain because you can get them when they're pregnant as well, but they're like sometimes gynae manages them as well. And basically, if you're really stuck on where to start with OBS and gynae, I would say like make a history for each of these presenting complaints and then like branch off what conditions would typically present with them, and then hopefully you feel a little bit less overwhelmed. And then the really big thing to say is like, yes, all of these happen in pregnant people and gynae patients, but so does like everything else that happens in 4th year. So like pregnant people can still have PEs and come in with shortness of breath and chest pain. They can still have reflux and get like, you know, burning pain or whatever. So don't forget about the like non-pregnant stuff as well. Okay, so in a past gynae history, what kind of things do you want to know? Past surgeries, yeah. And if someone's had a surgery, then your next question should be, why have you had it? Anything else? Okay, so I basically used to tell myself to be like, ask them if they've got any of the big, so miscarriages and pregnancies come in the OBS history. Malignancies are big in the gynae history. Yeah, so basically just check if they have any of the big headlining conditions in gynae. And if they do, so the past STI is sexual history. That's all also sexual history, Zoma. But yes, good. Okay, so I basically used to check, do they have any of the big headlining conditions? And often they will just tell you, like they will know if they've had an ectopic pregnancy before. They'll know if they've got gynae cancer. So like the thing that I used to find really effective was just being like, have you ever had to see a gynecologist before about anything? Have you ever had to have any surgery in your pelvis at all? Or what was it for, kind of thing? And they tend to be quite like aware of what went on. If they're postmenopausal, don't forget to ask like the age of their menopause, whether they use any HRT or not, because that's important. Okay, moving on to past gynae OBS history. So lots of you have been saying like any miscarriages, any past pregnancies, all of that we condense into something called a gravidity and a parity number. Does anyone know what either of those two words mean? Start with gravidity. Do you know, like, does anyone want to suggest what that could be? How many children? Close. Gravidities, pregnancies, including miscarriages, etc. Okay. Yep. Okay. So we've kind of. Yep. Okay. So gravidity is what Jessica said, which is the overall time a woman has ever been pregnant. Even if she's just been pregnant for like a single microsecond, it counts. And regardless of what happens to that baby, it counts into your gravidity. It's just the total number of times she's been pregnant. Parity, you divide into two different numbers. So it's like A plus B. And the first number is the number of like viable pregnancies. So some of you have been saying past 24 weeks. Someone said like pregnant and delivered. So viable by definition is like past 24 weeks, because it has to be that old to survive. Plus it comes out the mother in some way alive, be it like a C-section, a normal delivery. If it's not what, like if it doesn't survive past 24 weeks, or if it doesn't come out the mother alive, it's not a viable pregnancy. And it goes into the second number. So it's the number of non-viable pregnancies. Does that make sense? Yeah, okay, cool. And generally your two parity numbers, so like your 1 plus 2 or whatever, should add up to the gravidity. The only time when it doesn't is if she's currently pregnant and there's like an extra gravid in there that your parity numbers aren't accounting for. So we'll do some examples to make this clear. So the first one is Julie's 29 weeks pregnant. She's got 2 other daughters and she's never otherwise been pregnant, except for when she had those 2 daughters. They're not twins. What is her gravido and parity? G3P2. Perfect. Yeah. So she's a G3P2. Okay. So the next one is yeah. So she's 29 weeks pregnant. This is her first pregnancy. Yeah, exactly. G1P0. Okay, and what's the other word for someone who's a G1P0? What's another way to describe them? Primigravida, close. Primiparous, I think, is the official. Maybe primigravida is also used, but primiparous basically is that. Yeah. Okay, so Julie's never been pregnant before. She's not currently pregnant. Yeah, G0, P0, and that's also known as. Nulliparous, exactly, perfect. Yeah. Yeah. So Julie's currently 29 weeks pregnant. She's got 1 daughter, and she's previously had 1 miscarriage at 12 weeks. Oh, close. Yeah. So G3 para 1+1, because she's pregnant 3 times in her entire life, like currently pregnant, had the daughter, had the miscarriage. But one of them was viable, the daughter, and the miscarriage was non-viable. So that's why it's 1+1. Okay, and then this one, Julie is currently 12 weeks pregnant. She previously had twin daughters and 1 miscarriage at 12 weeks.
What is that?
G3 para 2+1, okay. So, okay, interesting. Okay, so if we think about, can you repeat why it's 1+1 again? Okay, I'll go back to that at the end, Patrick. Let's just stay on this one for a second. So if we think about Julie in this final scenario, and just her gravida, she's currently pregnant. She's had some twin daughters, and she's had 1 miscarriage. So in her entire life, she's had 3 episodes of pregnancy. So she's a G3. Her parity is like, how many times has she had a viable or a non-viable pregnancy? So we can all agree that like +1 is for the miscarriage. Yeah? I'm going to go with yeah. But whether it's like P 1+1 or 2+1 basically depends on kind of who's teaching you and where you read. On the NHS website and a lot of places online, it's 1+1 because they consider like twins and triplets to be still 1 unit of viability. Miss Kai Menser at the WIT will teach it to you as a 2+1, and she is a very experienced and like great obstetrician. So basically, when I asked her about this, she said like, it doesn't really matter which way you do it, but when you in your documentation like open this out and write, okay, so like para 1 twin pregnancy SVD and 1 times spontaneous miscarriage at 12 weeks, just be really clear so that if someone was to read it and be confused, they can find out exactly which scenario it is. Does that make sense? Okay. Going back to Patrick's, can you explain why it's 1+1 again? So she's only ever had like 2 outcomes of pregnancies. So she's currently pregnant. We don't know what's going to happen to that one. But in her 2 previous ones, she's had a daughter and she's had a miscarriage. The miscarriage is not viable. You can't include it in her parity. It has to be a +1 on the side. Does that make sense? And it's not viable partly because, well, she didn't carry it, but also because it didn't reach 24 weeks. Is that clear, Patrick? Yeah, perfect. Okay. So the other thing to note is, no, so the plus isn't like you add the numbers together. The plus is like the physical way you write it down. Yeah. So like, it's just the way you note it. Like I would write 1+1, I wouldn't write 2. Sorry, I should have made that clear. The other thing to note when you're doing your past obs history is obviously if they're not nulliparous, if they have had a child before, you need to check like what was the birth like, how were you delivered, were there any complications, were there any fertility issues, and for the current pregnancy, you need to check about any issues. And the like really easy way to know is basically ask them who they see for their pregnancy, what's their risk, because if they just see like a generic outpatient midwife and they're going to give birth at home or in a birth center, no one's really worried. But if they have a consultant for all of their meetings, then they've got some real conditions that need senior input, and like they might be giving birth on the labour ward. And that's when you can stratify them for their risk. Okay, so just quickly whizzing through the last few bits now. Menstrual history, what do you want to ask? Someone's already said it. Last menstrual period, yeah. Regular cycles, yeah. Cycle length, yeah. Good. How long does it last? Menarche and menopause, exactly, perfect. And And then the things that you want to look out for is with the regularity and cycle length. If they tell you that it's irregular, it's an oligomenorrhea. If they tell you don't have any, it's amenorrhea. And then with regards to the bleeding itself, heavy flow, you're talking menorrhagia, dysmenorrhea. What's the difference between dysmenorrhea and menorrhagia? So dysmenorrhea is painful periods, which can be light or heavy, and the menorrhagia is just heavy periods, and they don't necessarily have to be painful. Exactly, perfect. Sorry, someone was just typing it. And then IMB and PCB is intermenstrual bleeding and postcoital bleeding, and I would ask about them even if they tell you they're regular and their bleeding is normal, because both of those are red flags. Okay, fine. Cervical screening and contraception. What kind of things do you want to ask about cervical screening? What do we screen for in the UK? HPV and dysplasia, yep. So with HPV, what thing could you check that they've had? So I was really non-specific. In school, maybe like, girls definitely got it. I don't know if guys our age have got it. The vaccine, perfect, yeah. So you want to check that they get smear tests for cervical cancer, and there is like a solid pathway that you just memorize. PassMed's really good at testing you for it. I think like 50% of the gynae questions in PassMed are just them testing this pathway. And they get it every 3 to 5 years based on their age. If you want to check basically when was their most recent smear, what was the outcome, and even if that one was normal, you need to check, have there ever been any smears where you had to go and have like colposcopy or like a proper gynecologist look at it? And then check that they've had the HPV vaccine. Most women now should have. I think men as well. Someone might have to check that for me. And then finally, sexual health and contraception. Sorry, I forgot to add some animations for this slide. But again, I'm not going to like try and impart too much wisdom on these two concepts, because actually Gum and Jane Kavanagh's lectures teach it really well. My only advice will be like, find a flow that works for you, and even if you think it works, practice it over and over again, because a sexual history in an OSCE will just ruin you if you haven't practiced it. This is how I used to do it. I used to ask, do they have sex right now? If they do, is it with one person or many people? Okay, is that person male or female, or like both? Have you ever had any STIs or treatments? Do you have any right now? And go from there. Okay, I think it's Tina's turn. Oh, before we hand over to Tina, actually, does anyone have any obs and gynae questions about what we've been through? Hopefully now you feel a bit more ready to like approach a pregnant person or a gynae person. Okay. If you do, just put it in the chat. I'm going to stick around for the whole thing anyway, so I can answer them as we go. And Tina's made a really good point, which is the cervical screening pathway changed the year before me, so like 2 years ago. So just double check that if you're using certain question banks, which one they're asking you about. Cool. Okay, Tina, do you want to take control?
Yeah, I think I was always in control. I think I could see you clicking, and I was like, it's just me doing it. Okay. Is anyone on psychiatry or obs and gynae at the moment? You can just like raise your hand or say yes in the chat. Because if you're not, I'm impressed by you're on ONG. You guys have really know your stuff with ONG, like more than I did going into fifth year. So I'm here to talk about psych. It's quite a long block, like obs and gynae. It's a 6-week place. So you've got like a lot of time. You do have time to like, absorb all of the stuff, even though it seems like a lot of content. So just like as a specialty in itself, it's like a really large discipline. Just like with all of the other topics in fifth year, you just have to know at quite a general level in the end, even though it can get quite niche in the moment when you're on placement. But by the time you get to exams, or when you're in the middle of the exam, you realise that actually I don't need to know this on too deep of a basis. And the trick when you have a lot of content is to have good structure, so adaptable structures for history management, your notes, your thoughts, everything. And that really helped me this year. The main thing that I found with Psych was like there's a lot of new content, like a lot of new vocabulary, and quite abstract ways of thinking. But like I said, you've got time for it to sink in. And it just links with lots of other specialties. So you kind of realise that Psych comes into, like, people often have like multiple comorbidities, and like mental illness is usually one of them. I'm not sure if anyone's heard of the phrase no health without mental health. It was like a government strategy from like 10 years ago, and I didn't really quite get it until this year, but they were doing it on a kind of, oh, we'll increase like productivity if we spend a bit on mental health. But you'll still, when you do your placement, you'll realise that it is quite like an underfunded specialty. So I don't know how many of you use the curriculum map. Personally, I don't use it all too much, but I thought it would be quite a good place to start with, just by kind of ordering like the core conditions and the core presentations that you have to know. Like Preena said, we are not going to try and teach you everything on the curriculum map, like, because UCL covers a lot of stuff really well. But I've just highlighted in green the bits that tend to worry people, or people that are really unfamiliar. So we might have previous experience with dementias from neuro in second year or fourth year, things like that. But there's a lot of new things like psychotic disorders, affective disorders, personality disorders, and the somatoform disorders, which people tend to find, yeah, quite difficult to get to grips with. And then with the core presentations on the side, what I realised was really good about them is that that's really good if, like Preena said, with obs and gynae, if you think of like, how would I take a history from someone with memory problems, or how would I take a history from someone with low mood or anxiety disorders, that's quite good to kind of think about more on a practical level. Last year, I tried to organise my notes by condition, and then, sorry, in fourth year, whereas by fifth year, I was like, it's more useful to do it by the presentation. And go from there. So, right, then I kind of used some of my friends as a bit of a focus group of like other things that were quite confusing at the beginning. So history taking is, yeah, it is quite new, and you're dealing with a lot of unfamiliar concepts there. I'll go over that today. I'll say a little bit on the kind of categories of like mental illness, but the rest I think I'll probably leave for other presentations, because otherwise we'll take up a lot of your evening. But as Preena said at the beginning, like, just if there's anything that's worrying you, put it in the feedback and we'll try and tailor a session around it. Like the kind of pharmacology aspects of psychiatry, you don't need to know it in like a lot of detail, like all of the different, like, to the degree that you had to learn mechanisms of actions in second year, for example. But there are like practical implications. So drug interactions, different overdoses, and yeah, things to recognise like that. So we'll probably do a session on that, because that's always quite fun to talk about. Right, so the psych history, it's almost like it's like a long, because what you're supposed to do alongside the psych history is to kind of do the examination at the same time. So it tends to be longer and takes up a lot of time if you're going to do it properly. I've only done a handful like properly myself, and they did take like nearly an hour to do. That was like on a mental health unit where the patients, like, they were happy to chat because there wasn't so much else to do for them. But usually you would do like a focus history, like I said, based on the previous slides, and some other ones you'll learn about. They teach it quite well. It's like the heads assessment, that is like for adolescent mental health, or like how to, if someone's come in with a suicide attempt, how to talk about that. But yeah, so some things to think about is that the presenting complaint might not be psychiatric at all. They can come in with a physical complaint, and then whilst they're in hospital, they can develop something, or it can exacerbate their mental health or their mental illness. A past psychiatric history, some people will have a formal diagnosis, other people won't. just as you would do like with a normal history, if they're happy to talk about it. Go into like as much or as little detail as you can. Like some people you can't push too far because either, you know, they've gone through it so many times before and they just see it a bit unnecessary, or other people. So if you're talking to like a manic patient, trying to have any structure whatsoever is a real challenge. So you sort of have to do your best with the questions that you're asking. Family psychiatric history is important, but again can be quite a touchy subject. So just think about like, are the questions that you're asking like really necessary? And you will get a feel for it, and people will tell you like if they don't want to talk about something. I think the big factor, the big difference here is the sort of the personal history. I've sort of linked it with the social history. So can anyone think of some important questions to ask if we're thinking about someone's problem? Like, so say someone's presenting with depression, like why would we want to know about their personal history? Or what would you ask about? Yeah. Childhood, very good. Housing, very important. Yeah. Traumatic events, very good. Living conditions, yeah, excellent. There are like lots of models in psychiatry, so you might see a bit of an overlap, yeah, with like social determinants of health. Yeah, smoke, yeah, exactly. Drugs and alcohol, all really good. So, and also just everyone has their own style with history taking. So I've kind of got a very like loose framework here, but you'll have your own, yeah, hobbies and interests. That's really good. Why do you think that would be good to ask about if someone had depression, for example, or was presenting with low mood? Yeah, do they have a job? Also very important. Yeah, very good. Nice official term. So that's like a lack of pleasure, like in things. So it's a core symptom of depression. So a pre-morbid personality. When I was on my psych placement, they ask often because they didn't have time, but they were like, if you want to ring any of the family members to try and figure out what they were like before they were in this psychotic episode, so you can just sort of gauge a difference, so that the patient serves as like their own control, that's just reported by their family. You just also have to take it with a pinch of salt, because usually the family has the family can have a bit of an agenda as well. And the last thing, which is quite big for the psych history, is like a risk assessment. So in my head, I kind of made it into three things. So the first one was centered around harm. So harm to self, and then active and passive, those two things. So you could actively harm yourself, so people cut themselves or things like that, or you can passive self-harm would be like self-neglect. And so if someone's like withdrawing from society, like they're not going out, they're not looking after themselves, they're not cooking or eating properly, that can be quite an important thing to think about. Suicidal ideation or attempts, that's really important to ask about, because if they've tried once, they might try again. And then a psychosis screen. So people ask questions in different ways. They can say, do you feel like you're in control of your own thoughts? Or do you ever hear or see things that other people can't, or you can't explain? They're quite tricky things to ask about, especially if you haven't come across these in your personal life, you're not practiced at talking about them. So it's well worth sort of with your friends, like practicing history taking, just so you find some phrases that suit you and feel right in the moment. Because if you normalize things, or it comes across more natural, then people are more likely to share. Yes, okay. So I talked about a model, the social determinants of health. Has anyone heard of like the biopsychosocial model? Oh yeah, so Preena's just put in the chat also from others. That's a very good point. So people who are mentally ill can be very, very vulnerable to different forms of abuse. But yes, so it looks like a lot of people have heard of biopsychosocial. This is like a key buzzword, like always mention it if anyone's ask you like, okay, what are the contributing factors? Biopsychosocial. How are you going to structure your management plan? Biopsychosocial. It's always good. The thing about the formulation is that you can combine those things with these factors. So predispose, all the P's: predisposing, precipitating, perpetuating, and protective. And I've just put, I'm sure you guys know what it means, but just risk factors, triggers, drivers, and then like protective factors. So if we think about, let's stick with depression, what could be some predisposing? I think we've mentioned some of them already, but some predisposing ones, and just say whether you think they're biological, psychological, or social. So someone said living conditions, for example. If that was a predisposing factor for something like depression, how would you class that? Yeah, family history. That's so. A family history, yes. So there is actually a really something like schizophrenia, there's a really strong genetic component. So like monozygous twins have a very high like concordance rate with schizophrenia, and for example, so there is like a genetic component there. But as you said, Niraj, there will also be like a kind of social, well, a psychosocial component too. Living conditions are social, no support network is social, very good. How about a trigger? What could we think of some biological, psycho, or social triggers or precipitating factors? Yeah, traumatic event, very good. Yeah, grief, yeah. All really good. Yeah. Something. And how about some perpetuating factors? So a lot of this is interlinked. So you can see, like, I've got a table coming up, and you'll see a lot of things are in the same boxes. Yeah, neurodegeneration. Yeah, very good. So can you see how kind of biopsychosocial is trying to mix everything together, but at the same time you have to have some kind of way of separating them? Non-adherence to medication. Yeah, really good. I mean, so you can actually break that down, Jordan, non-adherence to medication, into biopsychosocial as well. So that kind of behavior. So do they not like the side effects on their body? Do they don't want to be dependent on medication, like psychologically or socially? You know, it's really not compatible that they have to come in for all of these. So say they're on like an antipsychotic and it's a real pain, they have to come in for all these blood tests all the time. That it doesn't fit with their work schedule or something like that, or they have to travel really far. You can kind of break everything down in that way. So this is a kind of formulation like of factors to consider. In reality, I haven't really seen a psychiatrist sit down and make a formulation. Like I'm sure they do, but it's just when the patients I've come across have either been like acutely like in A&E, or they've been like in an acute mental health unit where they have a sort of plan in action. The times that I've seen it being used is when there was a problem with, say someone needed to be discharged from an acute mental health unit, and there was a real problem because if he was discharged, he couldn't stay with family because they weren't happy to have him. He wasn't entitled to housing or benefits because of his immigration status. And there was just like a lot of other things going on. They were kind of trying to break down the problem in this way and come up with a management plan. But it is, yeah, I quite like it. Has anyone got any questions of it so far, or is that quite self-explanatory? Well, not really self-explanatory, but at least like you haven't seen it, like you've seen it once before you start psych. So the second one, which is quite new, is the mental state exam. So this is just like when you had to learn how to do like a cardio exam for the first time, and you had like WIPER QQ and IPA and all of these like acronyms. There's a new kind of like formula like for the mental state exam. Somehow you're supposed to do this whilst history taking or whilst observing the patient. What I used to do was when I was like jotting down things from the history, at the bottom I would just write a few things about their appearance, like when I would notice things about what they would say or do, I would just jot that down, and then later I would kind of fill out a more like formulaic thing, or type it up to put it in the notes. So I've in bold again, because I can't go through the whole thing, but we will do it in like a later session. I've just put some of the things that are new. So possibly mood and affect, those terms might be quite or new to, or the distinction might be new. Thought is like another category that is new and contains like a lot of new terminology. Perceptions as well. It's just quite difficult to sort of use the right psychological terms to describe what you're seeing or what you're observing from the patient. And then insight is kind of my favorite one. It's like, when do people know that there's something wrong? Because I find that really interesting when someone is acutely psychotic or acutely manic and doesn't see what the problem is, and in fact, like, why are you asking me all these questions? Like, because you're causing the problem. So a really good way to kind of learn about this and put it in action is to practice. When I first came across this, I was like, oh, I'll try and analyze members of my family, which was a terrible idea. I would not recommend that. So fictional characters are good to do. So I've got some here. I don't know if anyone wants to choose one character and we can talk about it. If not, I will make a decision. I mean, I guess, I hope everyone's familiar with that. This is what I was thinking about for most of the day. It has to be Gollum. Yeah, Gollum, and he's the alter ego. Okay, so actually, why don't we do Gollum? I think I don't have too many more. I have a few more slides, but we can spend a few minutes on this. So if we wanted to talk about his attire or his habitus or his hygiene, for example, like, there are ways of saying like, doesn't look nice, like doesn't look, or like is quite like, is not looking after themselves properly. Like, you can say unkempt, you can say like cachectic, or like, you know, undernourished, rather than like skinny, or like a large body habitus for like if they're overweight. Attire, appropriately dressed. Sometimes we had like a manic patient who was dressed like pretty much all in gold, which is, I don't even want something to comment on, because I was like, you shouldn't really judge people by what they wear, but it is part of the appearance thing in the mental state exam. So what about behavior? How would you describe Gollum's body language? I hope everyone's like knows who this character is. It's a character from Lord of the Rings who has this alter ego called Smeagol. So maybe I'm just showing a side of my personality that it's okay. So you could talk, yeah, so body language, eye contact, those kind of things. Speech, rate, rhythm, volume, other kind of basic ones, like you might have with manic patients, that if they have pressured speech, it's really difficult to interrupt them. They will just keep talking, keep talking, keep talking. Mood and affect are two things. So mood is like what they, if you ask someone how they're feeling, and the affect is like how, like kind of your assessment. So, and also how things affect them. So if you're talking about something quite serious, like a death of someone close to them, and they start laughing, then you can see that something is wrong with their, like, that they're not like reacting appropriately to that news. And you can also see whether their mood and affect are congruent with each other. So if someone tells you they're really, really happy, but they can't stop crying, or they're really, really sad, but they laugh like all the time, then it's kind of incongruent, their mood and affect. I think the thing that most people struggle with is thought, and breaking that down into kind of form, content, and possession. The good way to think about form is like connectedness of thoughts. Like, is there logical reason, like can you see the logical moves between their steps, or is it completely illogical and disconnected from each other? In terms of content, that's, yeah, so it's pretty much the substance of their thoughts. So if we take Gollum, for example, he's obsessed with like, you know, having the ring or something like that. Or if we take another character, yeah, I mean, almost anyone you can, like, any like fictional character you can analyze of having like overvalued ideas. So they have something that they think is like abnormally important, like to a degree that you don't really understand, that, or like it's slightly abnormal. But this is something that we should definitely cover in more detail, because I'm realized that I don't want to run out of time. So yeah, perception is how they're relating with the environment. So that includes like hallucinations, but also misinterpreting like a shadow for a figure, or hearing like clicks on a telephone and thinking that someone is recording them. And so you can see how, whilst you're taking a history, you can actually kind of categorize some of the things that they're saying into like, as if you're doing like a kind of psychiatric examination of them. But yes, so another thing to mention is, so, and this could well come up in an exam. So if you're struggling of things to say, you're like, this person doesn't seem to be like, they're depressed, but they're not actively doing anything, then negative findings are really important. So if the person's having, you know, their thoughts are their own, they don't have any kind of signs of thought possession, then that's quite an important thing to document. Just like if someone doesn't have chest pain, it's important to write no chest pain. Anyway, going back to something that might be a bit more familiar, is like with management. So I'm sure you're all familiar with the kind of conservative medical surgical stepped care. And you can mention, as we said, like the biopsychosocial approach, but you can also think about like stepping up or like escalating care and the different environments where it's appropriate to do that. So what you do when this ties in with GP, you look at what kind of level of like anxiety or depression can be managed in the GP, and when do you have to refer. And you usually have to go through certain hoops in order to gain a referral. So you start with the kind of lowest level, just reassurance and education, and then self-help. Has anyone heard of the IAPT, like improving access to psychological therapies? Yes, I can see a thumbs up. Good. Yeah, so it's a new kind of self-referral system. Don't worry, so I hadn't heard of it either. There's lots of services in Psych that I had never heard of. But essentially people can self-refer for CBT or like various forms of therapy. And what usually happens is that they make an online request, and they get a telephone call, and you get like, they get triaged like on the telephone for how urgent it is, and then they get put on a waiting list, which is not the most satisfying outcome for a lot of people. And so that's why that there's a lot of kind of NHS recommended like apps for like self-directed CBT and things. And then once you kind of work your way up, so you go through like cognitive behavioral, so I'm saying CBT like everyone knows what it is, but that's cognitive behavioral therapy. So it's a way of kind of reprogramming your thought processes so you don't get stuck down a negative spiral. And you can get special ones for eating disorders or like trauma focused ones as well. And that will eventually like scale up, and you might combine it with some medication. And if none of this is working, then you might get a referral to a psychiatrist. And if someone's having like a crisis, they can go to A&E. They might get medically cleared by the A&E team, and then the psychiatric team will like kind of take a history. And you might do that if you ever do liaison psych. You might see that in A&E, and then they might refer them to a mental health unit. If people have an established mental illness, then they might have a kind of crisis team that they go with, or they might have a plan. So if they are in crisis, they can like ring certain numbers, and if that still isn't working, then they can go to kind of a place of safety. But you'll learn all about like that when you actually do psych. I might be getting ahead of myself slightly. So coming to the end, just about classification of disease, because I find this is quite important. So if you think about how physical and psychiatric illnesses are different from each other, like what are some of the ways that you can think of any differences? I realize this is quite an abstract question for a Monday evening, but like one of the big ones is like visibility or like tangibility, or can you measure something? Yeah, exactly. So that's what I was thinking. Yeah, you can't measure it. And they try. There are so many surveys and like questionnaires that you can do to try and somehow like quantify like a mental illness. And you'll see lots of scales. Like you might have come across some of them already, like the HAD questionnaire in the hospital, for like hospital anxiety and depression and things like that. But that is one of the big ones, like you can't really measure them. And so that, how does this affect our like organization of the disorders? I'm just going to rush through this because I know we're coming to the end. Oh yeah, slightly different rules for children as per usual. But you will come across these two things, the DSM, the ICD. One is sort of like the American classification of disorders, and the ICD is like a more international classification. But in essence, they keep changing, they keep updating with new additions, and definitions change ever so slightly, and the criteria for different diseases change ever so slightly. UCL are not going to examine you on the latest definitions of all the different criteria for someone fulfilling like quite an, even for a common thing like depression, but like they will expect you to differentiate between something that is mild, something that is severe, and something that is life-threatening, because then you're going to be, that's all about being a safe doctor. So don't get bogged down and by all of the different details. And if you see something from the DSM-4 and it looks slightly different from a presentation that you've just had, like don't stress about it. You just, yeah, it's like guidelines changing. Like it's just exactly the same as psychiatry. So just as the last slide, I hope I haven't psyched all of you out. I was pleased with that pun if no one else was. And we'll be going through like cases in future sessions to hopefully make it more interactive. Oh, thanks so much. And hopefully I like integrating cases, so I won't just stick with psych, I'll include other things, and it does make more sense in the end, to the point. So Preena and I did OSCE practice together, and we we did a lot of our own things. So this was like a screenshot from one of the, I made like, well, I think we each came up with videos, and we had to do like mental state exams from the different videos, and make like little histories for each other, and that was really, really helpful. Just if you're about to start psych, I don't think anyone else said that they were on psych at the moment, just a couple of people on ONG, but there are some really good lectures that previous years have done, just on like specific things. Like I think Ahmed did a couple of really great ones. I think he did all of these actually. But I can really recommend those ones. They really helped me when I was in 4th year / 5th year. So yeah, if you, we're coming to the end now. So we've probably said it all a lot, but our big tip is to practice. Doesn't make perfect, but it does make you more like comfortable with the environment, and I think other people can pick up on whether you're comfortable asking questions or not, and if you're more comfortable, they're more likely to disclose. So it's definitely in your interest. Has anyone got any questions from either my or Preena's presentation? Oh yeah, there's one. Yeah, so in psychiatry you can also come across some quite difficult topics, like, and I just make sure like you can keep like a bit of distance from it, like, because you really want to empathize, but make sure that you're not like getting down yourself, and if you are, like, just make sure that you're talking to someone, because like there are a lot of topics that can be quite like triggering for different people, so definitely like support each other and make sure you've got like an outlet in some way. I think they do run a Oh, what's the workshop called? Someone help me. You know, when they sit down and they discuss a case.
You mean
It's
like the valence groups?
Yes, that's it. Valent groups. Sorry. I could only think of Banan, and I was like, that's definitely not the right word.
Sorry, I might have missed the last few minutes just then. I'm heating up my dinner, and the microwave doesn't have like. Basically, you can't leave it in there unattended.
So I'm just going to put the feedback form in the thing because I think everyone's done. So next week, I think, is me and James doing some pediatrics and some derm, but put whatever you guys want, and we'll look at the feedback for all the weeks. But yeah, everyone have a lovely week, and we'll see you next week.
If you have any questions, by the way, just